Hi, and welcome to episode 295 of the Untethered Podcast. Today we have Dr. Maddy Goodman joining us. Dr. Goodman is a board-certified orthodontist who co-owns Harmony Pediatric Dentistry and Orthodontics in Bethesda, Maryland. Dr. Goodman attended Duke University and majored in classical languages. She then completed dental school at the University of Pennsylvania and orthodontic residency at Tufts University. She is the past president of the Mid-Atlantic Society of Orthodontists and is the founder and chair of American Association of Orthodontists Sustainability Committee. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered Podcast. I am your host, Hallie Bulkin. I'm a certified myofunctional therapist, feeding specialist, podcaster, business owner, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, airway, tethered oral tissue, and pediatric feeding therapy space. If you're new here, I challenge you to keep an open mind and join my mission to spread this message far and wide. If you've been around since June 2019, thanks for being a loyal listener. As we jump into today's episode, remember to listen with correct oral rest posture. Tongue up, lips closed, teeth apart, breathe through your nose. Let's get started. Maddy, welcome to the podcast.
Thank you so much for having me. It's an honor to be here.
I'm excited to have you. I know a lot of people on the podcast know that I used to live in Bethesda, Maryland, where you practice, and now I'm in South Florida. But you're definitely one of those providers that we're always referring to because I know that you all get it. So I'm really excited to chat with you today and dive in. But I would love for our listeners to just understand a bit about your background, how you became interested in, the more myo airway holistic space. So will you start with sharing a bit about that with us?
Yeah, sure. So I graduated my ortho residency in 2011. And soon after, I moved back to Bethesda, where I am from. And I happened to get a job at a large pediatric dental and orthodontic practice. And that's where I met my current business partner, Heather Scholander, who's a pediatric dentist. And it's also where I was introduced to myofunctional therapy. I'd never heard of myofunctional therapy before, not in dental school, not in residency. But the orthodontist who owned that practice was very forward thinking. She did a lot of early treatment, and she already had a myofunctional therapist who would come into the office once a week, and they would co-treat patients together. She would do screenings, and then when the patient came for their ortho visit, the myofunctional therapist would see them. And that myofunctional therapist is Jennifer Triandafilou, who now teaches the Simon Says program. But she was my first introduction to it. And I really loved that aspect of collaborative care, and it made a lot of sense to me. And it was just a great working relationship, and she really taught me a lot. But as time went on, I still felt like there was something I was kind of missing. I would still have these cases where they had perfect tongue posture, and Jennifer did a great job, but they would still kind of go wacky, and it was frustrating to me. And also, I was sort of having a quarter career crisis where I was like, what is the point of what I'm doing? I'm just straightening teeth, and most teenagers don't care about the straight teeth, and then they don't wear their retainers and it relapses. And I was just kind of like, what is the bigger picture here? I was kind of searching for something. And also that's when DIY orthodontics was getting popular. And I was like, yeah, a robot could probably do this. So anyway, this all culminated in 2018 when the AAO, or American Association of Orthodontists, had their annual meeting in DC. And I brought my staff. We went for one day, and I was like, we need to go to one lecture. So they chose a lecture, and we ended up getting lost in the lecture hall and ending up at a different lecture. But we decided to stay. And the person giving that lecture was Joy Muller, who's a myofunctional therapist. And she was talking about airway and sleep apnea, and what you eat determines how you grow, and that mouth breathing can be a habit, and all of these things. And I really had this moment where literally a light bulb went off, and I was like, oh my gosh, this is the piece that I've been missing. And I almost had chills in the lecture hall. I was like, wow, this was kind of blowing my mind. And I had a few simultaneous thoughts at once. Like that was one. Two was, I think I ruined my 9-month-old son's life by not getting his tongue tie clipped when he was an infant because they told me he had one and we didn't do it. And three was like, this is what I want to do with my practice, is like have a practice that's focused on function and early intervention and collaborative care. And so that like Monday morning back at work, I went to Heather, the pediatric dentist, and I was like, this is the kind of practice we should have. And she had coincidentally recently been to a pediatric lecture that talked a lot about the feeding side of it and how that influences growth. And so we both got very interested in this topic. And like to say went down a rabbit hole is an understatement. Like I have never gone so enthusiastically into a topic like ever before or since. And so I was immediately like, read every book, read every article, went to every lecture, listened to every podcast. I listened to a lot of your podcasts. I listened to a lot of Stephen Park, that ENT from New York. I listened to a lot of his podcasts. I tried a lot of like myo adjacent appliances. Our kids were in myofunctional therapy. Like I like went nuts with this, like really nuts. But suffice to say, it planted the seed for Heather and I. And in 2019, we started the process of setting up our own practice. So at that point, the practice that we worked at had been bought by a corporation, and we just kind of knew that we weren't going to stay there long term. And we really wanted to focus on this, and we didn't have the freedom to do that at that office. And so we wanted to have our own thing where we could really kind of go full speed into this practice philosophy. So we ended up opening our own practice in November of 2020, and now we're about to have our 4-year anniversary, and it's been really great and really interesting. And now we can really just practice how we want and do the things we want to do. So that's the story.
I love it. I mean, it feels very similar to like some of what I did in the past, and, eventually went into practice for myself because I wanted to be, basically control, how I was practicing and what I was offering. And then I actually didn't get into it for myo, but I got into it for feeding, although I was working with like 24 months plus, had my own kids, came back from my first myo course, which by the way, I met with somebody, another speech pathologist in downtown Bethesda one day. We're having like coffee, and she's like, yeah, I found this myo thing, and I'm not really doing it full on, but all of my kids with like speech sound disorders are doing so much better. Like I'm actually graduating them faster. And I was like, wait, now you have my attention. What do you mean? Like those are some of my most complex cases that I can never seem to get out of therapy. And so I was like, all right, full attention, went down the rabbit hole, got into myo, and I'm like, the rest is history. Came home, realized that my then 24-month-old had a tongue tie that was never identified, but we had a horrible feeding journey, really, really challenging. Still breastfed her for like 13 months, very painfully. And I'm like looking in her mouth, I'm like, high narrow palate, tongue tie, lip tie. Okay, yeah, we got some work to do. And then, I knew differently for my second one, but it was around 2017, 2018, where I like totally revamped my own practice and just dove in to like everything, airway, feeding, myo, TOTS. And yeah, I'm like, the rest is history. And it was so hard to find a variety of providers that we could refer patients to even at that time. And so I remember like when you guys opened your office, and I remember coming to visit, I was like, oh, this is so nice to have somebody in downtown Bethesda. And then we moved, but we still refer patients to y'all.
Yes, I know. We refer to you too. Yeah, no, that's great. I mean, myo, like, it's very important for what we do in orthodontics in terms of stability and getting the results that we want, but it's like paramount in speech therapy. So I really don't understand that whole thing. Like, I don't understand why it's not like at the forefront basis of what speech therapists learn, but I'm sure that's another topic that you talk about with other speech therapists about, but
yeah. And feeding too. I mean, feeding basically, speech and feeding. Hi, what are we using? Our jaw and our tongue for both activities. And there's still this massive divide amongst speech language pathologists as to like whether myo is a real thing and whether tethered oral tissues are a real thing. And I'm like, are you guys kidding me? I mean, there are people who argue with, we teach compensation. Like they don't really need a lot of movement for the tongue to produce speech sounds. And we're like, what? It's kind of like, if you could see my face right now, people
Speech is
listening,
muscles.
like what? Yeah.
That's how you make speech, is with your muscles.
Correct. Yes. And like, yeah, very minimal jaw movement. I will give them that. But like our orofacial muscles need to work together. Right. So it's mind boggling to me, because I've gone over like sound by sound, like what is involved and how it can be impacted. And people still want to argue with you over it. And I'm like, that's fine. If you want to keep your patients in therapy forever, that's on you. But ethically, for me, I would love to see my patients come in, get the help they need, work with the team of providers that's necessary, which I know like you guys are also very collaborative in that sense, and get you out as fast as we can. I mean, it's still going to probably take a year or two sometimes, but let's not make it take 10.
Same. That's 10 years is not a practice builder. And same with ortho. Like, the goal is to get in and get out. Like, no one likes you that much that they want to keep coming for 6 years.
Yes.
It's not a good story.
Yeah. And I use this, I have this one story that I tell all the time of this kid who came to me. He was going into high school, and mom had said they had 7 other speech language pathologists over the course of his lifetime, like since he was 2. And I did a myo eval on him. I looked under his tongue and I was like, holy cow, like there was like webbing. I was like, this is one of the worst, like most obvious, like most severe cases I've ever seen. Scored as like a 2-year-old on our speech testing, which is very heavily rooted in like the R. So he could not make R for his life, but he also couldn't do other sounds. I can't talk today. I don't know what is going on. It's Monday morning and I'm making up new words. Okay. Sent him to an oral surgeon who did do the release. And he said, this is one of the most involved like cases I've seen on a child. Anyways, long story short, we did all the therapy leading up to it. We did all the therapy afterwards. We had a whole team approach, and he was graduated within like 6 months and went to high school speaking the way he wanted to, which for him, I mean, then you start getting into like having thoughts about yourself and your, just how you identify and how good you feel about yourself. And he clearly he flourished. It was really, really cool to see like how quickly, he was able to move with the right intervention. And I'm not like writing off all the other treatment he ever had, but to come to me still presenting as like a 2-year-old on speech testing tells me that was not very effective, the other interventions that they had attempted, and how quickly we were able to move him through with the right team approach was like just so, mind boggling to me, but at the same time, just like, wow, like this really is something. Like we really need to kind of dig our heels in a bit further and really like promote this, because when you share cases like that, I think people like really start to wake up and start to realize like no kid should be in speech therapy for 10 years. That's absurd.
No, there's something else going on at that point.
Yes. Yeah. Mm-hmm.
Yeah. And I do think that, we have relationships with a lot of speech therapists and a lot of patients that are in speech therapy in various, with various providers. And I do think that speech therapists have become a lot more aware of tongue tie, what it is and what it looks like. I think it's almost over diagnosed now. Yeah. But I think overall, though, I do think it's better that they're more aware of it than less. And I think like people like you with podcasts and getting messages out there, I think it's really resonated with a lot of speech therapists that maybe don't learn about it in school.
Yeah. I mean, none of us really learn about it. If anything, we learn that it's not a thing. It's so rare that you get someone who comes out of a program that even knows about myo or tongue ties. So it's mind boggling to me. Yeah. And it's interesting too, that you say that you feel like it's even overdiagnosed now, which I completely agree with. And I try, like in my courses that I teach, I try to really drive home the point that like, if we're going to diagnose a tongue tie, there needs to be a functional impact and there needs to be a physical impact. Like we need to see that tight tissue, and we also need to be able to list all of the symptoms that we're observing and how it's impacting them on a daily basis. And then we need to also intervene in other means. So I think it's really important, the work that obviously I do and other speech therapists do, and obviously, the expansion and, the growth that you're doing. But I also feel like we oftentimes need like body work. We need to address tension throughout the body. And I'll tell you, we've seen kids where we're like so sure they're tied, and 3 to 4 weeks in working with us, maybe starting expansion with they're working with body work, they look totally different. And like the anatomy things kind of shift, and they don't seem to carry as much tension. And I'm not saying it's not a tongue tie necessarily, but I really try to caution people these days to like running right into a tongue tie release, because sometimes we don't need that. And less is more, in my opinion. Like if we do all the things and we feel like it's still impacting and we need to do a release, 100% I'm on board. Obviously, we work with patients all the time getting released. They come to us because they need that pre and post-op work, but not every case needs to be released. And like I say that, and now there's people like on the other side, they're like, oh my gosh, you're going to make people run away from releases. And I'm like, no, my goal is to hopefully give people like the information so they can go have a conversation with providers. They get informed consent. They know like what the benefits are, what maybe risks there are, which there aren't a ton of risks per se. It's a minor procedure, but if you're not going to do the work, if you're not going to expand the palate and grow the jaws forward when that's needed, it's like, and you can speak more to that, I feel like it's got to be kind of like a holistic approach, not just like piecemealed things here and there. And it's a lot.
And an individualized approach, because we have some kids who present looking like super tongue-tied and they've totally compensated for it and have very minimal issues. And then you have kids that don't look that tied but have not had any progress with speech and all of that. So, we get patients asking all the time, like, do they need the release? Do they not? And we always say, like, again, try all the things first. That should be kind of like last resort.
Yeah.
The last thing that you try is, because the other part of it is there aren't that many risks, but it's not, it can kind of turn into a thing because there aren't a ton of providers. You don't want to put a kid under general to have a tongue tie release. Yes. They can do it later. There's other factors at play. So, we really try to be conservative about us recommending it as well. But we never, unless it's something like blatant, which is very rare that you have like an anterior tie where like the tip of the tongue is tethered. In that case, like, sure. But otherwise, we rely on the myofunctional therapist to make the final call. Like, we don't do all the screenings and measurements and everything. We refer.
Yeah.
But we like to be in on the conversation just so we kind of keep things conservative for the patient.
Yeah. How do you feel about a kid where we're pretty sure they may need a release, but they have a really high narrow palate, right? Because my thought process is you can release a tongue, but if it doesn't have the proper space to exist in, how are we rehabbing it properly?
Yeah, we almost always will recommend expansion first and then do the release second. Mm-hmm. So I do a lot of early treatment, definitely more than the average orthodontist. I have one, because I have like a special interest in it and I believe in it a lot. But two, like, because I work with a pediatric dentist and we share a lot of patients, she's able to kind of flag issues very early and kind of plant the seed. Like, you can kind of tell in a 2 or 3 year old if they have a high and narrow palate and the baby teeth are coming in crowded. In a 3 year old, you kind of know. So she's like kind of priming them for some more early ortho. So yes, again, it's on an individual basis, but if there's a kid who we feel like needs a release, but they're not having any sort of major issues with feeding and speech from it, we'll wait until they're ready to do the phase 1. We'll do the expansion, and then we'll have them go for the release afterwards.
I love that. Yeah, that's kind of aligned with like how we approach things. And we try to explain to parents that, because a lot of times parents will come to us for like, they'll say, we're calling for a tongue tie evaluation. And we're like, what are the symptoms? Like, there's no such thing as a tongue tie evaluation. It's a feeding evaluation. It's a myo evaluation. That's a part of like what we look at and what we assess and what we kind of figure out, is there a functional impact or not? But we get called for that so often. And then it's really, we feel like there's a big part that falls on us to kind of start educating and saying, okay, we know you came to us. And yes, we agree that we need to intervene and we're going to start doing that. We would also love for you to go and see another provider to assess the hard tissue. Like, we do soft tissue, they do hard tissue. The bone, want to make sure the teeth are coming in, and we see a ton of these kiddos with like those high and or narrow palates. And so that's, how early do you start intervening with expansion?
So it depends. I've done expansion on kids as young as 4, but they have to have a special circumstance for me to go in on a 4-year-old. Number one, they have to be a good patient. Like, I want this to be like a fun and a good experience. I don't want them to be traumatized. They have to be a patient who's going to like lay in the chair, and you'd be surprised. There's some 4-year-olds who are very good patients. Yeah. Like, better than 13-year-olds. So that's one. 2 is they have to have something like pretty disfiguring. I don't know if that's the right word, but anyway, something pretty major going on, like a very large mandibular shift, posterior crossbite, like, or an underbite. So the 4-year-olds I've done expanders on are, I corrected an underbite. It really bothered the parent, and so the parent was very motivated to help him with that. So we corrected his underbite in like 4 months, in and out. Like the younger the kid is, the more easily things move. And again, I go very slow with everything, but I try to make these younger kids only in something for like 6 months or less. So anyway, I'd say an underbite, a major asymmetry or shift crossbite, and then otherwise, I'm going to probably wait until a kid's older. In like a 5-year-old who has super narrow, super crowded, all the sleep problems, already had tonsils and adenoids out, then I would go in and do some upper lower expansion if they need it. I've only done that a couple of times. 6 is where I would probably start with that. I'd probably rather start with that. And then by the time they're 7 or 8, then you're getting into the more traditional phase 1.
Mm-hmm.
I put an expander in my son when he was 4. But again, I wouldn't just like do that on anyone.
Yeah.
So they have to have a pretty significant issue for me to go in on a 4-year-old.
Yeah. When we moved down here, so Lily had intervention, my older one who's now 9, when she was starting at 4. And we moved down here and she had ended up having another like phase of expansion when she was, I want to say 6-ish. But my other one, my younger daughter, who is now 6, started at 4 as well when we moved down here, but she had croup 9 times as a 3-year-old. And both my girls are like, they're the good patients. Like they will just lay in a chair and let you do anything. They're like so easy. I'm so grateful for that. But I will tell you, her croup cleared up. Like she maybe got it once the following year. And then, I mean, you could sneeze around her. She would get a cold on like the next day. And the day after that, like we'd be in croupville. And they were constantly putting her on steroids. And I was like, there's gotta be another way to like, there's something's got to give. And she had like chronic croup even before she was 3, as an infant and, into toddlerhood, into the preschool years. And so I was very, very grateful for the expansion because what I think it did was it opened her airway enough that if she did get sick and she got inflamed, it just didn't get as severe as croup. And, I was like, thank goodness for that. So, and it's also interesting too, because both kids were like delayed getting their teeth and then they were delayed starting to lose teeth. But with the expansion, it was like we started to expand and all of a sudden teeth got wiggly and teeth started to come out in my older one. And same with my younger one. I feel like she's been more on track now, even though she was like later to cut teeth because we were able to expand. So that's been very cool to see. And like we did CBCTs on both of them. So it was very cool. I didn't do an after. Did I do an after? I think we did an after on Mia. Maybe we didn't. I don't remember. Lily, I have a before and after, which is just, they're like 2 years apart, but like 4 and 6. And it's incredible to see how much like her airway opened, her sinuses were no longer full, her like, you could see her turbinates like on the CBCT where you like, things were obviously very fluid filled and inflamed when she initially had her CBCT at 4. And so it was like so eye-opening to me to, to start this conversation of like early expansion. So I love that you get in there earlier than most because it's so hard to find someone who will expand that young.
Yeah. It really is incredible. I call it phase 1A and phase 1B. Like phase 1A is like if they have this problem or if we want to make space, and then phase 1B will be when they get their front 4 incisors. But it is incredible how much like if you go in before all the permanent incisors start to come in and you make the space, they come in pretty straight.
Yeah.
Whereas you're right, like if they're really crowded, teeth take a long time to come in because they don't have room. So they try to come into like a funky space. They either come in behind or they come in really high or they get impacted, worst case, or they pop out the baby canine early, which is also not a great situation because most people shouldn't be losing their baby canine at 7 or 8. They should be losing it at 10 or 11. So anyway, and then you lose that space. So suffice to say, I mean, it's really incredible. I have a number of patients, like either of my staff members or of other dentists who are like, let's just do whatever you want to do. And I'm like, okay, I'll put in expanders at 6 or 5 And it is just incredible what we see with these kids. Like, you really change a lot of things about the trajectory of their growth. But that being said, it's not a super popular treatment philosophy amongst orthodontists. So I kind of try to tread the line and be careful with regular patients. I always give them the option, like, you could do nothing now. This is what that path looks like. You could wait, or we do something, and this is what that looks like. So I never tell people they need to do it, except if they have something really off. But I think that it is very hard to find orthodontists who are comfortable treating young kids. Because we don't learn about this in residency either. Like, the way programs are structured, and it's not the program's fault per se, it's just like that's how the patient flow is in residencies. You see a lot of like older kids, and in older kids with severe crowding, you're looking at taking out a lot of teeth. Like in my residency, we took out teeth on 75% of the patients that we saw, because that's the philosophy of the people who were teaching us. That's how they learned and that's how they practiced. But also, we were seeing older kids, and you have to make concessions when they're too old to grow the bone, if you will. But I think in the end, it is kind of confusing. It's confusing for patients, because when they're told by the pediatric dentist, go get an evaluation when they're 7 or 8, and they go for a couple opinions, they're going to get 3 different opinions.
Yes.
Because every orthodontist has a different philosophy, uses different things, is coming from a different place. Like in orthodontics, there's a million different ways to treat everything.
Yeah.
And especially early, when there is always also the option to wait. So, again, I think that's why it's been really great having this growth in awareness amongst speech therapists who also have a lot of access to kids and parents, to kind of educate them on how important it is to have enough space for the tongue, and because having space for the tongue and having to me, like, that helps them form the sounds for words. Like, if your mouth isn't the right shape, you can't speak clearly, I guess. And, but also, like, doing it young, because the other part of it is that expansion's really only predictable non-invasively, in my opinion, like 9.5 and below. When they reach 10, 11, 12, you can't really change the shape of the palate. You can change the shape of you can straighten teeth until you're 100. You can change the alveolus, the dental housing, like the housing of the teeth, but you cannot change the shape of the palate unless you do something more invasive, which who wants to do that? Nobody.
Yeah.
So I'd say like 8 or younger is like ideal.
Yeah.
To start.
Yeah. No, that's, I know, it's just, I think, so important. We keep talking about collaborative care. And I know that you guys work very closely with myofunctional therapists, speech pathologists. So are there other people that you find yourself like referring to regularly? Who is that?
Yes. So we work a lot also with a physical therapist for TMJ issues. TMJ issues are largely not dental related or occlusion related. They're muscle and ligament related. So we work with a physical therapist. He's awesome. He's part of an office called the Center for Facial Recovery in Rockville. And we just tell our patients, like, the myofunctional therapists are for the muscles inside the mouth, and he's for the muscles outside the mouth. So actually they collaborate a lot on some of like the adult cases and people with pretty severe pain. But we refer to him and work with him a lot. And they're great. They look at the whole body, and they look at your posture, the patient's posture, and like what you were mentioning with like fascial release and tension release. He's really great at that. He's helped me a lot, not on with my jaw, but because I have a lot of like overuse injuries, and so does my husband, who's an orthodontist. So Carl Chua, shout out. He's great. So we do refer a lot to ENTs. I always tell my patients to ideally get 2 opinions, because ENTs also lots of variety and variability. Yeah. But we have a lot in our area who are very good, and who my patients are very happy with. Again, like, ENT is another thing. Like, no one wants their kid to have surgery. Like, but they're the ones who diagnose the sleep apnea. They do the sleep studies. I think tonsils and adenoids out are still the frontline therapy for a kid with diagnosed sleep apnea, or who checks a number of boxes on the pediatric sleep questionnaire. We don't routinely do the pediatric sleep questionnaire. If in our evaluation a lot of things kind of come up, I will give that to the patient along with an ENT referral and say, fill this out, take videos of your kid, take sleeping, and go to the ENT. So I'd say ENT, physical therapist. I don't do a lot with feeding, but my partner does because she's seeing kids starting at like 1.5 or 2. So she refers a lot to feeding therapists, which I know is like with speech and myo. We work with a dentist who does a lot of TMJ and does more of the imaging side of things like CBCT and MRI. And if they need like a splint, like she deals with that. We refer a lot to oral surgeons, but not for like myo related. We don't have a CBCT machine in our office. We're very X-ray conservative, I would say.
Mm-hmm.
So I don't really ever use CBCT to diagnose airway problems or to help diagnose them. But I do take a lateral ceph, like all orthodontists do, and I always look at the adenoids in the lateral ceph. And if the adenoids look large to me, I will email to the patient and say, you should have an ENT take a look at this. But usually there are other things that the kid has by that point that I've already said, you should probably talk to an ENT.
Yeah.
You can visualize them pretty well.
Do you find that some of those tissues calm down with expansion, like the adenoids or the tonsils, or you're not really tracking it so much, so it's hard to say?
I don't track it that much. I do kind of eyeball the tonsils during an exam if there are other, like an initial exam, especially if there are other like things that the parent has already said yes to, like snoring and problems breathing through the nose and whatnot. It's very hard to say because one, like the child over the course of like a year, a child's going to look different. They're, I don't know what that age is where the tissues start to recede a bit. Another thing is like, I actually, when I put the expander in my son at 4, he didn't have a crossbite, but he had a lot of issues with like mouth breathing and snoring. And it did help his snoring. The problem was that once I took the expander out, he refused to wear a retainer. So there was not really a great way to retain it. But anyway, and so he's going to get another one. But suffice to say, before and after, I took a video of his tonsils and I actually showed the video to this ENT who's in our study club. And I was like, look, his tonsils look smaller. And the ENT goes, well, I don't know if his tonsils look smaller or his oral cavity just looks bigger because of the expansion. He's like, it might just be all relative. But then I was like, well, does it even matter? They're taking up less of his airway.
Right.
So I don't know. I don't track that, but I think if it's a thing, I think that's a great outcome all around.
Yeah. Yeah. Audrey, I don't know if you're familiar with Dr. Yoon, Audrey Yoon.
Yes.
Yeah. So she had spoken to our Myo membership and presented this data. I think it was before it was even published. And now it's been published sometime. I don't have it in front of me, but sometime in the past couple of years where she talked about how expansion does open up the airway, like, several millimeters or what was it like? For every millimeter of expansion, it's a certain percentage that the airway becomes more open. And so I feel like that definitely helps. And I think that's what I saw with like my own daughter with her whole croup story, and why, if there is inflammation, like it's just not having the same negative impact to the same degree. And then my first daughter, we had done a slower expansion route with her, like using an ALF appliance when she was 4. She's since has gone into rapid palatal expansion, but her tonsils were almost touching. And within like a couple months, because I was crazily taking pictures and documenting everything because I was just, kind of curious, her tonsils went down to, I couldn't even see them anymore in her airway. They were like a 1. And it was like, they were like a 3 and like almost 4 to a 1 in a couple of months. And I was just like, okay, I mean, that's fascinating. And that's where I started asking people, like, what are you seeing? Because like you said, she had maybe had a couple millimeters of expansion at that point. It wasn't anything like huge, but she did start to expand. And I was like, all of a sudden her like tissues just seemed to be like calming down. And I was like, this is so cool.
Yeah, no, it's great. And Audrey Yoon is just, I think she's so awesome because she not only like helps champion these things, but she also does it in a way where she's doing research at Stanford and like publishing these very high quality papers. She's really making a difference. I think she's great. Actually, when I was president of the Mid-Atlantic Society of Orthodontists, we get to organize a full day lecture for the society, and she spoke at our meeting. Like I got to choose.
Oh, amazing! That's
she spoke for half
amazing.
a day. As did then in the afternoon, it was Stanley Liu, who's
Mm-hmm.
the ENT she works with, and
Yes,
Dr. Zaghi spoke for a little bit too. So
amazing.
anyway, it was amazing.
Yes, I know. It's so fun to hear. And I know that like they're all involved in this ongoing research, which is so very cool because, you know, I feel like we're seeing things happen, but it's nice to have like some data to back up what we're seeing because it doesn't exist to the same degree that I feel like it needs to. And I've always been someone who's like, if I'm seeing something clinically and I'm seeing it repeated, like I clearly know it works. We're going to keep doing what's working. But yeah, it's still nice to have just a little bit of, you know, data to show when you expand the palate, like it does grow the airway.
Yes, orthodontists are very big on studies and data, and as you know, it takes studies and data a long time to catch up to what people are doing clinically.
Mm-hmm.
And there's so many naysayers in orthodontics about all of this, so this data is very necessary for anything to ever change. In how we're taught. So
yeah, and I know that she had referenced, I think it was at a Boston University. It's coming back to me, but it was something like if you like for every millimeter of skeletal expansion, I think it was like 2.3% of airway growth for every millimeter of expansion. And I was like, I don't know what that looks like clinically other than my kids benefited, but I'm like, it was just really cool. I mean, there's the other thing too, where we were talking about TMJ, and this is something that I reference oftentimes where like 97.92, if my brain serves me correctly, I've said it enough. Hopefully I'm saying the right number of patients. And this is like pediatrics and adults with TMJ issues have a myofunctional disorder. And it's, you know, and you had mentioned that a lot of the TMJ stems from like the soft tissue dysfunction, the muscles, and it's not necessarily, you know, always hard tissue. That's, I mean, I know there could be obviously issues with the joint. I'm not the expert here, but we do see a ton of people come to us, adults alike, because we work with peds and adults in Myo that have jaw issues. And I feel like we're seeing more of it in young children now than we were seeing even 5 years ago that are having like issues with their jaw. Do you see that? Like, is that, I mean, you guys are pediatric and you mentioned you do refer to a PT who specializes in facial pain and like jaw and everything. But is that something that you all see?
Yeah. So when I said hard tissue, I meant like with their bite and their occlusion.
Yes.
So like their bite, it definitely has a lot to do with hard tissue bone,
right?
And like
in the joint, right? Yeah.
And like kids with like rheumatoid arthritis and whatnot, like they're all much more prone to having TMJ problems. But like the average kid and young, I feel like I've always seen it. Usually most TMJ problems start to crop up around the time of puberty. They're more common in girls. But I think, again, it goes hand in hand because when you have someone with a short ramus, because of like if they're mouth breathing or have their mouth open all the time and they have that very vertical pattern with a short ramus and the mandible set back, those are the patients, again, who are a little bit more prone to having TMJ problems because every time they bite, they're also in like a posterior occlusion. It's like the class 2 patients, where that's when you have more of that tendency of the disc to slip and for them to get the clicking. Okay. So I'd say like those kind of patients, again, also maybe with more of like a weak musculature. Then you have the patients with a really strong musculature who clench and grind, and they're more prone to having muscular pain as well. I definitely see a clinical correlation between people with tethered tongue, and well, again, they have a myofunctional disorder, and then that translates into disc dysfunction. But yeah, I mean, I think that I've always seen in teenagers, especially girls, some TMJ issues, but where it really starts to manifest and become detrimental to the person's life is when they're an adult. So a lot of teenagers will have a lot of clicking and crepitus. That's like that when it's like the bone scraping bone, like that'll crop up in teenage years, but it's not that common that teenagers will actually exhibit symptoms. The symptoms start to come when you're older, and I guess when this has been going on for longer and longer. And I don't treat a ton of adults, so I don't see it. But a lot of my adult patients, like, and I will get patients that come and say, "Hi, I have TMJ. What can you do?" I'm like, I can give you Carl's card. I mean, there's not a ton, but I have some like patients in their 20s who've come back and who've come in. And there was one girl recently who came in. She has a little bit of an open bite, and I just saw the whole time her tongue's just like, and I was like, "Where does your tongue rest?" And tons of TMJ issues. And so again, that's a myo PT referral.
Yeah.
Because in a person that age, like there's not a ton you can do orthodontically to help that. So anyway, it's a little harder to explain in a kid, like, okay, that's not something I usually lead with in a consult. Like, oh, if we do this, like you could prevent TMJ issues, because prevention it's a little harder of a sell.
Yes.
It shouldn't be, but it is.
Yeah.
But again, I think just being aware that TMJ issues are, again, very multifactorial.
Yeah. Yeah, no, I totally agree that it's harder to sell prevention unless, like, once in a while we'll get a parent who comes to us and be like, I suffered from this, this, and this, and I want my kid not to. What do we do? Right? It's like, unless they come to us with that, I'm like, okay, why are you here? What's the chief complaint? Let's circle back to that and focus on that. And then maybe down the road, we can like talk about how the work that we've done is also hopefully prevented these other things. Yeah. But you mentioned your interdisciplinary study club, which when I was living there pre-pandemic, I had started one, and then I feel like it kind of fell off because of the pandemic, and then I moved. So I love that there is still one in the area. So will you talk about that a little bit?
Yeah, so this actually started before COVID. A different myofunctional therapist started it, but it was just like 5 of us. And it was like me, the physical therapist, the pediatric dentist, and then one ENT, and then a couple other speech therapists. And we would just like go out to dinner and talk about stuff, which was honestly great. It was really fun. And then COVID hit and that ended. Then we started our new practice, and we were like, let's revive this. So we had it in our office, and we just like invited whomever. And then now, like 4 years later, we have like 30 people on the invite list. And whenever anyone like expresses interest or wants to come, whoever wants to come, you're welcome to come.
Yeah.
Just let us know you want to come. And we have it at our office, and we've actually like kind of outgrown our office's space. We were actually talking about for the spring having it at a restaurant because we just don't have the space anymore. But, I kind of just took aspects of other study clubs and other like lectures that I've been to, and we kind of took all those things that we liked and didn't like about them and put it into ours. So like, I'm always like, oh, I wish we had more time to like talk to other people. And so we have always built in like a lot of time for like sitting around and networking first, and we have dinner for everyone. And then we always, every time, like everyone goes around and introduces themselves and says where they practice and what their area of interest is, because I think that's great, because also then people bring their cards, and someone's a dentist in DC is like, I've been looking for a therapist in DC. And, it's been really great for like inter-referrals.
Yeah.
And then also we very rarely have a lecturer come in. We've had a lecturer come in once, and we're going to do another one in the spring. But most of the time we just pick a topic, and Heather and I will get literature. We'll try to get literature from different specialties, like an article, like a study, like from orthodontic and from pediatric and from ENT. And then we circulate it ahead of time and we talk about it. We've done that a few times. We've done people watch that like open wide documentary on Netflix, and we talked about that. We have a lot. It's more like a discussion. Instead of just like a lecture. So it's been really great. It's been very fun. It's been really great in terms of getting to know other practitioners who think the same way in the area. So I would encourage anyone out there who wants to start one. I totally would if I were you. It's been great for everyone in it, I think.
Yeah, I love that. I love that. At the time that I was doing it in person, I also was just like, it's hard because not everybody has access to the professionals in their immediate area, or they know who they are yet. And so we're always encouraging therapists to go and find them in their area. But we started our online study club, which is mostly for like speech therapists and OTs and like RDHs and some dentists that are doing myo specifically. So I always love hearing about more collaborative like study clubs out there, because it's so important. And I will tell you, like, some of my most favorite times were sitting around a table with like a laptop open. We had like a case that actually, I think, because a lot of it was like there may be 10 people around the table, but we were all sharing cases. And so we would like pass that case, like the images, CBCT images around, and the addition of information from every specialty was so different, but so eye-opening sometimes. And we were like, this is what we need to do more of. Like, we really need to be collaborating so much on cases because we all have our own specialty and like lens through which we see things. And it's so helpful to have those conversations. And I know it's like challenging. We can't all just sit around a table and discuss every single patient case all the time. But I think when we do discuss certain cases, I think it opens our eyes in ways that we then see something in another patient, right? That it's like, ooh, okay, this would be a really great referral for the PT, or this is a great referral for, it kind of just helps you figure out who needs to even be on the team. And then we can more easily collaborate and send the patient out. And like we were talking in the beginning of the episode, get them in and out as fast as we can, because no one wants to be in therapy and seeing a bazillion providers all the time for the rest of their life.
Right.
Yeah.
No, it's really been great and very eye-opening. Like, as an orthodontist, like, we see studies and articles that come out in the orthodontic literature, but we don't know what ENTs are being told. One, and two, a lot of orthodontists only, like, once a patient's done, when they're like 13 or 14, you never see them again. At our practice, Heather sees the patient until they're like graduate college. So I do see cases long-term, but not that long-term. So it's very beneficial to talk to general dentists. And I love asking them, like, what do you see? Like, what are you seeing down the line in terms of like periodontal health and teeth health? And what do you wish your patients would have gotten out of orthodontics when they were younger? And all of them are like, they need more expansion, bone, because everything collapses over time regardless. So talking to general dentists who kind of see it way down the line is very beneficial. And also the ENT, like the ENT in our study club, I think we've really opened his eyes to a lot of things. But also, like, from his perspective, like, there's one thing he said that just sticks in my mind all the time. He's like, if you have a kid who then turns into an adult with a very high vaulted palate, very narrow, that means that their entire sinus apparatus is also very narrow. Yeah. So if they ever need to have a sinus surgery or anything, like, it's going to be very hard for the ENT to ever do what they need to do. And he's like, there's very little you can do about that once a child's finished developing, or a person's finished developing, when everything's kind of squished together. And like, that's what you were talking about. If all the tissues, the soft tissues of the sinus and the nose are all squinched into a small space, any hint of inflammation, there goes the airway. And so, like, hearing that, like, it just, when I start to think twice about, like, oh, does like every patient need expansion and blah, blah. No, I don't think every patient needs expansion, but I'm like, you're really doing them a service, because what if something happens when they're an adult and they can't fix it?
Yeah.
At least you're opening up the space and giving them the best anatomy they could possibly have, given their genetic predisposition for whatever.
Yeah.
So, I think that really has helped me, like, justify things when I hear a lot of, like, naysaying orthodontists who don't, believe in doing much.
I mean, I feel like I've never seen anything negative come out of expansion. I feel like, if anything, it's always been very positive, just in terms of general health, like holistic health. And then, you're talking about kind of like even sustaining that over a lifetime, like things are going to kind of collapse over the course of lifetime, just, I guess, from natural growth. But I feel like we have this like epidemic right now of just like very narrow faces, right? Very narrow orofacial complexes. And, so that collapse that normally happens, it almost seems like it's happening on a more drastic level. And, I was that 20-something-year-old who was constantly on meds for sinus infections. And I kind of was just like, I've had expansion, I had braces, as a kid. I ended up going into adult expansion, which, they say that, I was in it for 2 years. So it was like slow, and it sometimes did not feel so good. I did not go into like a MARPE or anything, which I think to kind of break the suture line is really like what a lot of people are talking about these days, but that kind of scared me at the time, to be honest with you. And it seemed very, very invasive. So I do have more room for my tongue now, but even after all of that, I was like, something is up with like my nose, and I ended up having nose surgery 2 years ago because the septum was almost like fully blocking the left side of my nose. And I was like, you couldn't really even see it that well because it was more posterior. The anterior portion of my septum was actually like relatively straight, like a little turn, but like nothing that warranted like surgery per se. And because of that, I then had like very inflamed like turbinates. I also had inflamed nasal swell bodies, which I had never heard of before. So I was like, oh, so basically there's things growing inward from the outside wall of my nose and things growing outward from the inside wall of my nose. So not only am I blocked on the left, I also am having a hard time. Like it's very turbulent. Like it's hard to breathe through my nose, and my entire body was inflamed as a result. And so I ended up having the surgery, and my body just dropped 10 pounds after that. It's like all this inflammation just like cleared up when I could breathe again. And so that's why I think I've also become such a big proponent of like early intervention myself and like referring out when we can, because I'm like, I mean, honestly, the surgery wasn't the worst thing in the world, but it's really uncomfortable to have that surgery and not be able to breathe through your nose for a couple of weeks. And no one wants to have to go through that if you don't have to.
Did you feel like you couldn't breathe well through your nose before? Like when you'd be like, or could you not really tell?
It's funny because I couldn't really tell. And I think there's a lot of adults that we've worked with that they'll go to ENT and ENT will do the scan and they'll say like, you really can't breathe out of one side of your nose very well, can you? And they're like, then, they'll kind of like, I mean, I guess when I plug it and you ask me and I'm cognizant about it, like, okay, now I can kind of see a little bit of a difference. But it's so fascinating to me how many adults will say to me, I had no idea what I was missing out on until after like that invasive procedure. So I feel like as adults, like, I feel like we should know, but at the same, and I'm in this specialty. Like, I feel like me more than anyone should know. Like I would do like a mirror test and blow and like the circle on the left would be smaller than the circle on the right. But I was like, I can't feel it that differently because I feel like my body was just compensating to the best that it could. Who knows? Yeah. Yeah. It was kind of wild.
I'm going to make an appointment with an ENT after this. Might as well get that checked out.
It was wild. I mean, and I also feel like pregnancy for me made like I had like a bump that developed on my nose I didn't have before. So that was also kind of a sign for me that like carrying that extra weight, the extra inflammation in my body when I was pregnant. I know a lot of pregnant women tend to have like greater levels of sleep disordered breathing, even upwards of maybe obstructive sleep apnea. And so I think that was kind of eye-opening for me too. And I was like, why do I have a bump here? Like things must be like something must be collapsing, like something is off. So I did have that like shaved down as well when I had the surgery, and I ended up just having a complete rhinoplasty because I was like, if you're going to put me under, we might as well just fix the whole thing. So just go for it. But no, I will say that I can now, like I feel the difference and I can breathe a lot easier. And if I get a cold or something, it's not as debilitating in a sense as it was before. Yeah. And I don't get sinus infections anymore either. I haven't had sinus infections in years.
That's great.
Yeah. So definitely some benefits there, but it was invasive.
Yeah.
It was invasive. Now you, I know, have also had articles in, like there's some involvement with medium.com and Parent Magazine articles. Will you share a little bit about that with us?
Yes. So when back at my old job, in like 2018, 2019, when I was like full on into this, I had a patient whose mom is an author and journalist, and she had recently come out with a best-selling book about parenting and behavior and children's behavior. And so she gave me a copy and I read it, and I noticed that there was only a very small part about sleep. And so once she was in with her daughter, and I started talking to her about the importance of sleep and how it's tied to behavioral problems and ADHD and how, about the mouths and how they're shrinking and all, I really like gave her an earful, and my assistants were all laughing. They were like, there goes Dr. Goodman talking about tongues again. But it really like caught her interest. And a couple months later, when she was back, she was like, so I decided to research an article about what we were talking about. So I was like so excited, and we kind of kept in touch, and I'd answer some questions for her. And then like several months later, she told me that it had been picked up by medium.com, and they were going to have like turn it into like a feature article, and promote it a lot. And so she came out with the article. I sent you the link to it.
I have it.
It was a very good article, very well written and very well researched. And I think it's had like over 20,000 views, like in the first few weeks that it was out. I think I shared it, or someone shared it on the myofunctional Facebook group. This was like years ago. But it got a lot of positive feedback. And of course I was like super excited about it. And then after that, she was asked to do a spin-off article for Parents Magazine. And so I actually had a quote in that article, which was very exciting. And we have that article up like on a plaque in our waiting room, and parents read it like all the time, and they ask us about it all the time.
That's
They're like,
amazing.
oh, that article in your waiting room with I think my kid has blah, 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 blah. It's been great. And at that point, I was also very big on promoting people to like stop using the pacifier. So I think that's a big part of that article on parents.com. I think she included that.
Yeah.
And you can't access that article anymore online. I looked before this.
Yeah.
But I have a hard copy of it if you want me to.
Yeah, I'd love it. I'd love it.
I can send it.
And we'll definitely link the one that's linkable. We might be able to link the one that's not the PDF, but we'll stay tuned on that.
Okay.
But no, yes. I love that. So thank you for sharing that, because
it was super exciting.
That's awesome that it's in the waiting room and parents are actually reading it and then they're asking you about it. Like, that's so cool.
Yeah, like every week they ask about it.
It's amazing. So, that is amazing.
So that whole thing was very fun, and she's really a great author. She's moved on to other things now, but it was a fun project.
Yeah. And now I know you mentioned you've treated like your own kids too. So how is that all going with whatever you want to share with us?
Yeah. So after I heard Joy Muller's lecture, and my son was 9 months old, and I was like having a panic because when he was born, the pediatrician in the hospital actually was like, he has a tongue tie and he has a narrow palate. And my husband and I thought that was like hilarious. We were like, oh, like, I guess he's going to need an expander. But he was able to latch right away. First of all, I didn't know that they like even diagnosed narrow palates in infants. But anyway, he latched right away. And my daughter, who has no hint of a tongue tie, who's older, was 3.5 at the time. Like, she had a terrible time latching, and I had to use that guard for 2 months. And finally she got it, but she had a really hard time. And I was like, well, my son is like 1 day old and he can already latch, so he's fine. But I didn't know.
Yeah.
I didn't know any of this. So anyway, fast forward to when he's 9 months old. His mouth's hanging open all the time. He can't breathe through his nose. He has like all the things. So I took him immediately to an ENT, because that's who our pediatrician referred us to for the tongue tie, our current pediatrician. And the ENT was like, he's 9 months, like he's past the window for doing it as an infant. So you don't want to like put him under for this. So we didn't do it. Then it turned out he had an abdominal hernia, so he was going to have to get it repaired when he was 2. So, and he did that at Children's Hospital. And so I went to an ENT at Children's Hospital, and I convinced them to do the tongue tie release at the same time as he was getting his hernia repair. So the ENT that he saw there was great. She said that she felt like it would be too much to take out his tonsils, which are huge, to take out his tonsils at the same time. So she took out his adenoids and did his tongue tie release, and he had a very, very thick lip tie. So I was like, yeah, sure, just do that too. So, and he was 2. So we did that at 2. We did no exercises before, no exercises after. He's 2. Like, it was all, it just wasn't happening. But almost immediately he had a really bad like lisp. I guess, he was like, his speech improved somewhat immediately after the tongue tie release. Then when he was 4, still had a lot with the snoring. I shoved an expander in him. He is not a good patient. I had to like hold him down. I don't do this to other patients, but he didn't have a crossbite or anything. So there's only so much we could expand on the top, but I definitely noticed his snoring it resolved pretty much. But it came out when he was maybe like 4.5. And then again, when you have like a crossbite or an underbite and you expand it and correct it, it holds pretty well because it's held by the occlusion. When you don't and you just expand, you need to do something to retain it. So I think he lost some of it, and he's now 7.5, and he's about to get his full phase 1 with like upper and lower expansion. But anyway, fast forward about a year ago, he still can't say R, so he went into speech therapy. Well, first we tried myo, and we were terrible. Like, we just never did the exercises, and we were just fail. So he now for the past year has seen a speech therapist who their kind of model is that they do 3 Zooms a week for 15 minutes each, so that we don't have to do the exercises. It's like just built in. So she does kind of like a combination of myo and speech, and his speech has gotten better, but he still just struggles with the R, like just saying it properly. And so very recently she was like, hey, like, he still just has this little bit under his tongue. And I looked, I'm like, yeah, I was like, we just need to have that re-release. So we're going to do that on the horizon as well. But that's kind of the story with him, is that he's headed towards some more expansion and a re-release and continue with the speech therapy.
Yeah.
My daughter, when she doesn't have any of the speech or ties or anything, her teeth just came in like funky, she just looked real. Her incisors are down here, her laterals are up here. She had a really gummy smile. This is when she was like 7. She got her teeth pretty early. So when she was 7, put her into upper and lower expanders. I can explain a little bit more about that, about my like phase 1 protocol in a minute if you want.
Yeah.
But upper lower expansion and upper braces, and she had everything for about a year. Came off. She went into an upper retainer. Now she's 10 and a half, has lost almost all of her baby teeth. I'm not planning on doing braces on her again. She'll probably just need like 6 months of aligners when she has all her teeth. Like things have retained pretty well.
Yeah.
And I have on my dresser her before 3D printed model and her after, and I look at it all the time because her palate just, it's incredible the difference you get in a 7-year-old. But if they don't have a crossbite, which majority of patients don't have crossbites, they just have constriction and crowding, upper and lower. If you don't do anything on the bottom, you're not going to get very much out of the expander. You need to do something on the bottom as well.
Yeah.
And if you do, and they're in it a year, and the change in the shape and the anatomy of the palate's incredible.
Yeah.
But they have to be young.
Yeah. Both my girls had upper and lower already, but I feel like we're headed to more upper and lower for both of them too. So I would love for you to explain your phase 1, because I almost feel like what we did, even though they were young, was phase 1, but it wasn't, they put them in a myo brace afterwards to help guide continued growth. And I was kind of like, I don't know if I buy this, but we'll do it. To be completely honest, my now 9-year-old at the time, like this was like a year and a half ago, she could not keep it in her mouth for more than an hour. She would like gag on it and spit it out. So I was like, that's a waste. We're clearly going to go into more expansion. But then she was 4, 5 at the time. She would actually keep it in all night. And so I was like, okay, we see. And then she leveled up to like the next level because she had a tiny little mouth. And so leveled up to the next level. And so I was like, okay. And then I guess you're supposed to like kind of chomp down on it and chew on it. And that's like supposed to be normal, which, okay, whatever. Popped a piece of it out. It became moldy. I was like, that's it. We're done. I'm never putting one of these back in your mouth again, because that's just another whole health issue that we're going to create. So anyways, now there is somebody in Boca who actually is like an orthodontist who's doing expansion work that I found recently. And I was like, okay, in the next phase, because we used to drive to North Miami, who I love our dentist there, but it's just so hard. Like they can't miss so much school, and like they miss a day of school every time we go. So I'm like, we need somebody who's like 10 minutes away from us. So we thankfully have somebody now. But yeah, I would love for you to like share like what that phase 1 looks like.
Yeah. So the majority of patients who come in 7.5, 8, 8.5, average patient is crowded, maybe a little bit class 2, like lower jaw kind of back, but very narrow, upper teeth crowded, lower teeth really crowded. So you always want the upper to fit kind of like a hat or like the lid of a box over the bottom. And so there's a limit to how much you can expand if you just put in an upper expander, because the top will start to sit outside the bottom, and then you've created a worse problem. So you need the bottom to kind of follow along the top. And there's, in orthodontic school, there's like a major article and a big principle that you learn, that you like cannot expand the intercanine width. Like you can't expand where the canines are for stability reasons or periodontal. I'm not sure. It's been a long time since I was there. But suffice to say, this is when they still have their baby canines. And so when I talk about lower expansion, we're not actually expanding the base of the mandible. You're just expanding the dental arch, like the housing of the teeth. And you're really just uprighting things. So the cause of the lower crowding is because the body always wants to have that relationship where the top fits over the bottom. So if the palate is narrow, when the bottom teeth start to erupt, they erupt kind of tilted in and like squinched in. And so that's like where, when the prominent incisors, which are large, start to come in, they have a smaller circumference of a circle to erupt into. So they come in crowded. So basically, what we're doing on the bottom is uprighting. There's 3 different ways you can do that I do that. One is with braces, like braces on every tooth, and the wires they get stiffer and stiffer every time you come in, and they are really great at creating like that nice big U shape. And in a younger kid, yes, where the tooth goes, the bone goes with it. So I put a brace on every tooth and looks great. That's one. Two is with aligners, like Invisalign. If you want a big change with aligners, you need to wear them all the time, even in a kid. And not every kid is going to do that. So I'm very hesitant to get into like the full-time removable appliance with any kid that's 7 or 8 years old. But if they just need, if the upper is super narrow or they have a hint of a crossbite, and they just need a little bit of expansion on the bottom, I will do 12-hour wear of aligners just to get a little bit of it depends on the case. So aligners are second. Third is that I'll use, it's like a spring jet uprighting appliance. I call it a lower expander, but it's like an uprighting appliance. This is great for when they're still in full primary dentition or the 6-year molars aren't in all the way and you can't. I'll do it off of the baby molars, but basically it's similar to like a lower, I forget the name of it, but it's like a kind of like the lower Hyrax with the key, but there's no key. It's a spring. It's a NiTi coil, so the parent doesn't do anything. I compress it every 6 weeks, and it very slowly goes to its shape, to its like original shape, and it will expand over time, the lower arch. And I can, if you want, I can like, I know it's hard to explain and visualize, but I can send you a picture if you want. So that's for the bottom. On the top, I've tried everything. I've tried all sorts of expanders and whatnot, and I've really settled on, for the most part, something called a Haas expander. It's a tooth and tissue-borne expander. So there's an acrylic pad that sits up on the roof of the mouth. It has a Hyrax screw, but it's really great, especially for the people who have a very high, narrow arched palate, because if you just have something on the 6-year molars and you're expanding back there, you get really wide in the 6-year molars, but you don't do much for the anterior palate and the anterior of the mouth, which the majority of crowding and constriction is at the front of the mouth. And so this appliance I found is really, really incredible at changing the shape of the palate, because you have that acrylic pad like pushing on the anterior palate. So I can send you a picture of what this looks like too. The only time I don't use a Haas is if I'm also using a face mask appliance, which is a headgear that's used for underbites for class 3, because you attach it. I use a more traditional Hyrax, like a single bar Hyrax expander to attach the face mask to. But that's for the kids that have underbite. So yeah. Oh, one more thing. So I usually, and then if the front teeth come in kind of wacky, I will do braces as well with the Haas expander. So typical phase 1, upper Haas expander, upper braces, lower full braces or lower expansion appliance or lower aligners. I'll use class 2 elastics to help with the overbite. I like the phase 1 to not last any longer than a year. So they're in it for a year. We take it out. Usually they go into a removable like Hallie retainer for nighttime wear. I don't have them take the retainers to school. On the bottom, I'll use a clear, like Invisalign style retainer. I'll monitor the kids at their cleanings if they're a dental patient, if not like every 5-6 months while they're getting the rest of their teeth. And then most patients require a second phase later to kind of finish things up. If they have a deep overbite, that's something that's ultimately corrected when they have all their permanent teeth. So I tell all patients to expect something later. But now with aligners, like I'd say more than half my teenage patients are in aligners. Aligners are great. They can be faster than braces. Like a lot of these phase 1 patients, I try to get the phase 1s as far ahead in the orthodontic process as possible, so their time in phase 2 is less complicated, less invasive, shorter. I rarely take out permanent teeth because we do so much expansion. I think a lot of crowding is just a width issue, but there are some kids that are so crowded that they also have a length issue. It's more rare, but in those cases, I can really tell the parents, like I can see it a mile away if I think they're going to be a 4 by extraction case, and I tell them like, you can either just have the extractions later and not do phase 1, or we could develop their anatomy. There's still a good chance you're going to need extractions because they just don't have the arch length to fit all their teeth. Like you can expand all day, but if they've lost length in the primary dentition for whatever reason, you might not have room for all the teeth. So anyway, that's my long spiel.
Thank you. So I have one question, because I've looked at the Haas before, and I know that I think it depends what lab is making it, because I've seen like different variations of what it looks like, but it almost looks similar to like the DNA Vivos appliance, but without like the front load springs on it. Is that accurate, or is it completely different? And it's just like the images I'm seeing are confusing.
I'm not totally familiar with is the Vivos the removable appliance or a
It's
fixed?
removable, and it has the
Oh,
acrylic on the palate, and it goes like, so yours is fixed, right? And the Vivos is
it's
removable.
fixed.
Okay.
So you know what a Hyrax
Yes.
is?
So my
Like the
kids had the
Hyrax is like
Hyrax. Yeah.
so it's a Hyrax, but the spring is embedded in acrylic, and the acrylic go. You know what a Nance is? It's like the acrylic
Mm-hmm.
button. Anyway, it's
Yeah.
fixed. It's glued around the sixes.
Okay.
It's a Hyrax. Same thing with the key, but instead of it just being
Yeah.
metal, that screw, the one that sits up by the palate, is encased in acrylic, and the acrylic goes up and rests against the
Yeah.
palate.
Okay.
So it's
Thank you.
fixed.
Thank you
So
for
it's
explaining
different.
that. Yeah.
Yeah. You might be thinking of a Holly is like a removable retainer. A Holly is like what you're talking about.
Okay.
What you're talking about is like a Holly with like springs on it. Like a Holly is like the one that comes in and
Mm-hmm.
out with clasps,
Yeah.
and there's the acrylic on the palate. So
Yeah. I
that's
mean, I guess, but the Holly doesn't have like the adjustable component down the center, right? Because like the DNA Vivos that's removal has like what the Hyrax
oh
has in terms of like turning
yes,
the key in the center and the
yes,
acrylic. But I think a big difference is like
you're right.
sometimes they'll have springs, especially towards the front, not necessarily on the sides, but like for the central incisors. And then it will have, but it is removable. It's removable.
Yes, I call that a removable expander. I
Okay.
don't use those,
Okay.
but I have at my old practice, and the kids just don't wear them, and they don't
Right. I
anymore.
feel like there's such a
But yes,
compliance issue.
that's like a Holly with an expansion screw.
Mm-hmm. Okay,
Yeah.
cool. Thank you. Thank you for explaining that. Yeah, because I'm like, I know I've seen pictures of them in the past, and I just was like Googling too. I was like, let me
Yes.
pull up a few pictures while we're talking. And then I was like, okay, now I remember. And I think there was a big difference between like the Holly doesn't have the
Yes,
you're
you're
not
right.
turning a
You're
key
right.
anymore, right? It doesn't have the metal down the center.
Right.
Right. Okay.
Yes.
Cool. Awesome. Thank you. Well, this has been amazing. Is there anything that we haven't touched on that you want to cover before we wrap up?
Well, I just want to throw out one thing about what I've been working on
Yeah.
now with the AAO, and that's that I do a lot with their sustainability committee. I actually started it for them, and so that's been my main extracurricular for the last year. So one of the things that we've been doing is we're hoping to flesh this out even more, but have a collaboration with a company called TerraCycle, which is a very well-established private recycling company. They have operations in lots of different countries, but a very robust one here. And they're the only company that's recycling Class 2 medical devices. So they recycle, for instance, used toothbrushes,
Wow.
used gloves, used dental aligners. So one thing that we've been working with them on is kind of offering their dental aligner recycling program to the public, and they just released it. So basically, I know for all the dentists and orthodontists out there, but also for people in your profession who go through a lot of gloves, you can order off the TerraCycle website, terracycle.com, boxes that are like recycling receptacles that then you send back to them and they recycle. For gloves, even if they have saliva on them, as long as they don't have blood on them, you can recycle them. They have a box for used toothbrushes, and they have a box for any brand of dental aligner and aligner packaging. So you can order those off of that website. So that's just, I think it's our profession in the health field creates a lot of waste, a lot of plastic waste, and
Yeah.
a lot of it's unavoidable because of OSHA and because of the tools we
Yep.
use. But I think it's super important for us to recognize that and be conscious of that and do little things, like any little amount helps, like whether it's recycling or not getting out plastic bags in your practice or not mailing out a bunch of stuff, whatever it is, every little bit helps. So just wanted to put that PSA.
No, I love that. And there's a bunch of, I call a scrunchy, but semi-crunchy moms who are also practitioners, that both moms and practitioners who listen to this podcast, that, even in our day to day, we're wearing gloves, a lot of times if we're working in the mouth or using tools or anything. And I know a lot of us have like tried to figure out ways that we can use tools that are, able to be used across patients. But for many of us who are like on the go during the day, it's like you either have a big arsenal of tools, or patients bring their own. But either way, there's still so much waste. And that's always been in the back of my mind. Like, how can we eliminate a lot of that waste? And I think like in my practice, one of the things that we've done is we will use those tools that can be, sterilized to the extent that that's possible. But gloves, like I feel like the one thing that we have not been able to get away from, because we used to like mail out kits, or we would, have a same kit for every kid. And then I was like, enough. we're not doing that anymore. Not everybody needs the same tools. Let's figure out what they need. And then we'll get, those tools. Let's try and buy tools that are not disposable, number one. But, again, sometimes there are things that are not made in things that can be reused, and just in the medical in our space, like you said, there's certain laws and certain regulations that really do hold us to a very high standard. But man, I've always thought about like gloves, because sometimes we'll put on a pair of gloves and take them off and have to put on a new pair of gloves just in a single session. Or you pick something up and you're like, I have to take that glove off and like re-glove. So yes, I love hearing about things like this. Like, I'm very excited. I had never heard of that before. But we will definitely, I'll link to it. I'll make sure people are aware of it. So thank you for sharing that. And then tell us, where can everybody find you, Harmony Bethesda?
So we are on Instagram. I think we're at Harmony Bethesda, and I guess Facebook too. Mm-hmm. I gave Hallie my email address, so if anyone has any questions about any of the things that I talked about, I'm happy to help. So, and if anyone's in Maryland, I'm happy to see them.
Yes.
I'm in Bethesda, Maryland. Yeah.
Well, amazing. Well, thank you so much, Maddy, for joining me today. This has been so informational. I know our listeners are going to love this. And because, again, like my practice is in that area and you all are in that area, I'm hoping this also just kind of kicks up some more, people finding you through the podcast.
Great. And you too. And thank you so much for having me. I've been listening to your podcast, as you know, for a year. So it's a very big honor to be here. So
thank you. Thanks for listening to this podcast. If you found value in this episode and want to hear more of these myotots, airway, and feeding related episodes, be sure to leave a review on Apple Podcasts and share this episode on your social media platforms. You can access free resources and all I offer at halliebalkin.com, or pop over to @HallieBalkin on Instagram to get all the latest updates.